Good morning or good afternoon, everyone in Europe, and good morning in the United States. I'm very pleased today to present the fourth edition of our webinar series, The Hospital of the Future, presented by the project ODIN. The webinar of today is focused on the enhancing healthcare processing with deep learning. This is one of the topics that are extremely relevant for the project ODIN. The webinar of today is going to be chaired by Professor Dimitrios Fotiadis from the University of Ioannina. And the agenda, as usual, is split in four parts. One is the introduction that is going to be given by Professor Fotiadis. And then we have three guest speakers that will address different topics around the central matter of using artificial intelligence in the hospital, in healthcare processes within hospitals. And then we will have a time for the questions and comments from the floor at the end of so the process is very simple. The session will be recorded, and this is something that you have to take into consideration. And then you can post your questions in any moment using the question and answer button. And then all these questions will be taken by the chairman in order to organize the discussion at the end. So I give you the floor, Dimitrios, for you to introduce our speakers and then start with the presentation. Thank you.
Thank you to all. First of all, good afternoon to all our participants. This is one of the very important webinars that we're organizing within the ODIN project. And on ODIN, we're focusing on the smart hospital of the future. Now we're leaving behind us, let's say, in the webinar series, the robotics, and we're going to AI. So today we're focusing on to AI, and particularly we're focusing on the deep learning and use of deep learning in the hospitals. With us today, we have three exceptional speakers. We know all of them very well. They are very active in the field. And I would like briefly to give you an idea of who they are. First of all, we have Dr. Bucur. Dr. Bucur is a senior researcher at Philips. Philips is participating in ODIN project. She's participating also in work package 6 of ODIN project, where we're developing all the AI models for all the use cases that we have described within ODIN project. Anca will give a talk, on what is happening today on AI in the hospitals, because this is the very important thing, how AI today is used in the hospitals. Then we have Professor Constantinos Pattichis from Cyprus. Kostas is a professor of biomedical informatics there, and actually he will provide us about the trends and how he believes that this will develop, and see what actually a new researcher or what can be done in the hospitals. Then, as third speaker, we have Professor Dongmei Wang. She comes from USA. She's a professor at the Georgia Institute of Technology and Emory University, and actually again is professor of biomedical informatics. And May will focus on a very specific topic: how big data are generated within a hospital, and what is the effect of using the hospital, what is the effect of using the big data in the hospital. So we'll start with Anca. Anca, please start your talk. You have around 10 minutes.
I will start with the current needs, opportunities, and the current adoption of artificial intelligence in healthcare. As we all know, the current adoption does not fully match the expectations. However, there have been very large investments and there are significant results that are already making their way into the clinic, as well as if we look at the needs and we ask why AI in healthcare, there are significant trends that support the introduction of AI. So healthcare systems are under huge pressure to deliver high quality and efficient care to a population that is growing. And they have to do that while being faced with a significant deficit in the workforce. So the World Health Organization emphasizes that by 2030, there will be a deficit of 18 million skilled healthcare professionals. So that gap needs to be bridged somehow. And technology and AI would provide opportunities there. Also, chronic diseases account for almost 75% of all deaths right now, and 1 in 3 adults actually suffer from 1 or more chronic diseases, which is a huge percentage. Because of these very large costs, on the other side, if we look at reimbursement, the models are changing with increasing demand for evidence that better patient outcomes can be delivered with lower costs. At the same time, people are increasingly using personal health devices, which generate large amounts of data, but so far, we still need solutions to make that data useful and actionable because it does not receive the use that it actually deserves. So you can see on one side that there are significant challenges to cope with the growing demand with a shrinking workforce. And on the other side, you see that there are opportunities for better quality at a lower cost. On top of this overburdened system, we've all been going in the last 2 years through this COVID pandemic, which put even more pressure onto this system and actually forced it to shift towards a new model where there is more emphasis on prevention, there is more emphasis on remote care, and there is a higher uptake of technology into care. So actually what was demonstrated is that decentralized health and remote monitoring can help improve patient outcomes, their safety and their comfort, while as well helping to lower the costs of healthcare. So at the same time, we are faced in this context with a shifting patient expectation where they expect to receive more support on prevention, as well as receive better care and becoming more involved into their healthcare. So becoming equal partners with the healthcare professionals in accessing healthcare resources. So in this context, artificial intelligence can help enhance the human experience. That means both on one side, the healthcare providers supporting them with decision making and augmenting expertise in the delivery of care, as well as improving their environment. So making their environment more efficient through improved operational efficiency, better resource management, and better workflows. And on the patient side, they need to be empowered to manage their own health, both on the prevention side as well as on recovery and management. But then we still need to figure out how to go from AI development to AI adoption, and to get all these benefits. Actually, what we need is the ability to scale up. And if we want to scale AI in healthcare, we need to focus on a wide range of topics, but basically on main 4 areas: people and their experiences with AI, then improve the technology and better processes for accessing data. We need to partner with the healthcare professionals. We need to gain their trust and to show that AI can indeed provide benefits to them in an efficient and safe way. And this needs to be a very large ecosystem. There is a huge amount of decisions that are made in the context of healthcare, in the healthcare workflow. And to adopt AI in that context, a large amount of players need to contribute. So this ecosystem needs to be widened and to be more efficient. So more specifically, of course, data privacy and adherence to all privacy requirements is fundamental, because only that way we will actually get the trust of the patients and of the healthcare providers to bring AI into the clinic. As well as we need to look at trust in our models. That means performance. That means maintaining and monitoring performance at all times, but as well understanding of those models in terms of explainability, and as well as avoiding bias, or at least identifying any bias in that model. So that means access to data that has sufficient diversity and sufficient volume to develop models of high quality. And of course, these models cannot be just deployed however we want. We need to feed them into the current workflow, clinical workflow on one side, and on the other side, they need to become an efficient part of the hospital infrastructure. So they need to fit with the hospital infrastructure. And yes, we also need help on the regulatory side, because AI has somewhat different requirements on the regulatory side compared to software, for instance. And this is why, for instance, the FDA is looking into models for unlocked AI, where models can be refined to improve their performance and to adapt their performance to the data, as well as more requirements of proving that the model performs well on local data. So basically local training and validation, either to a local institution or, for instance, to a local country, to a local population or region. And I don't want to go next into actual models or solutions. I only want to talk a little bit about an approach which lately has been getting some traction. And this is federated learning. Why I want to mention federated and distributed learning is because it is still a technology that's evolving, so it's not finalized solution, but it does seem to have some benefits with respect to privacy and adoption. And as well, it seems that healthcare organizations can get behind that faster and can achieve results on a short period of time. So one interesting result actually here is the article on the left that has developed. So 20 sites worldwide very quickly came together to develop a model that predicts clinical outcomes in patients with COVID. And this would not have been possible if they needed to aggregate all that data and to have all the processes in place to bring all that data to a single site. So why this approach helps in such condition to scale is because it allows to train and validate algorithms without moving data. So basically, it brings the compute to the local data, and it only transfers back for the global model the model parameters. So in this context, local data custodians will remain at any moment in full control of their data, and as well, this can leverage privacy benefits because data will never leave the administrative domain of the organization that collected. As well as this approach has promise in the future for model customization, so tailoring to the population where it is applied, so to the local site. And it would help address the performance concerns and the bias issues that have been noticed, for instance, when a model has been developed with a limited amount of data, there's not diverse enough. For instance, data coming from a single site or a limited number of sites. So this is why this could be an approach, for instance, that could help in large scale development and training of AI. Now I'd like to take a step back in my last slide and reflect on my hope for ODIN's contribution to this ecosystem. I think that we can create proof points for AI adoption in our network, so we can demonstrate the feasibility and the high value by validating models in use cases that are very impactful. And this way, we can support future adoption of AI by building trust in our network of hospitals and beyond that. So showing that we can safely help them solve problems in an efficient way and help them improve quality and lower costs. I also believe that in ODIN, we can innovate with respect to the methodologies, with respect to the approaches and the processes for artificial intelligence development, for the validation of models, and as well for the deployment of models. And I think we can become a part of this global ecosystem that is being developed by creating opportunities for scaling up in the project and beyond the project. So thank you. This concludes my presentation.
Anca, thank you very much for this very exciting presentation and putting the things together about AI in the hospitals. Now let's proceed to the next speaker. Costa will propose to go with May, since May should go to teach in person, and have the input on how the big data are generated within hospitals, because this is the question that Anca left with the federated learning. May, please go ahead.
Thank you for swapping with me. So let me share with you my screen. I'm going to share with you, because I work on the forefront with the clinician in the hospital all the time, I'm going to share with you what we're doing here as one example on the big data. Okay, so I was borrowing this slide from my colleague, but this is also what we do. We basically, talking about the entire healthcare, we categorize it in these 4 big areas. One is targeted for population, because we know that for a person in the lifetime, when the person, 90% of costs happen during the early years when they're born, and also during the aging years. The rest of our life, most of the time, we're very healthy, not much cost. So that's why population, we target these 2. And then in terms of technology, we focus a lot more. Big data is on harmonization, as well as delivering the big data solution. That's the human in the loop for the AI process. So that's why I want to show you, these are the kind of data we collect in the hospital. So basically, we collect a lot of clinical data. So this is to follow the clinical care workflow. What's the physician's clinical notes, the initial assessment. And then we also collect a lot of measurement data. So for example, for using imaging, and both imaging, either radiology imaging or histopathology imaging, go for more precise diagnosis from initial assessment of what's going on inside the body. You use the imaging, and then you go to more precise diagnosis. And then go to therapy. That's when we also have many other data we also archive, talking about patient monitoring, talking about during the surgery process. We actually, one of the issue right now on surgery is how to reduce the surgery cost, complication, and death. So this for cancer, we also have a lot of this kind of radiation, this type of therapy. So as a result of it, at least locally, we have been trying to start we call it a digital transformation in a hospital. All the things I have shared with you in history, we start converting infrastructure-wise. For example, for imaging, convert from physical film to the digital radiology, whole slide image, the digital radiology. And then for the histopathology, we actually convert for the traditional, the patch, small patch microscopic imaging. Now we use the robotic control to scan the entire images for the patient. So basically every patient you get a few slides. You do 24-hour, one patient, you capture the whole thing. And then meanwhile, this is the one new thing being introduced in our hospital. We started to implement clinical genomics. In addition to that, we also because the insurance started working with us, so we have been able now to start incorporating at-home based patient monitoring during the entire treatment process. Traditionally, it's only at hospital. Now it's already going outside the hospital. In addition to that, this is a way where we're introducing novel technology using augmented reality, virtual reality, and now we also call it intelligent reality. The main reason is for at-home based recovery rehabilitation. This play a critical role. So in the hospital, we use robotic surgery, but outside the hospital, we start using AR and VR. Of course, for this rehabilitation, especially during pandemic, we do a lot of these. Also, we started having a hospital incorporate this data. So on the clinical genomic, one of the major issue right now is it's actually not exactly the same as a clinical diagnosis. Sometimes the genomic prediction presented the opposite the suggestion in comparing to physicians' experience. So that's why one of the major hurdles, I would also say, is one of the major procedures taken in the hospital is to improve the clinical genomic, the reliability and the reproducibility. I'm just showing an illustration here where it's very easy for you to have molecular data, high throughput that has noise undetected. It's going to impact the final result. That's why there's a big push, not only in our hospital, but also in the US. Even FDA got involved in terms of standardize the omic, clinical genomic, focusing on reliability, reproducibility for this. And then at home, as I share with you that this is also currently, the US is the insurance started paying for it. So as a result of it, it has already now, our clinic start giving patient the wearable sensor to take it home to monitor. In addition to that, we also introduced the at-home rehabilitation, as I mentioned about the intelligent reality. So we also collect those kind of data. So this is some examples right now, because the pandemic causing more adoption right now. So part of what's going on right now on the rehabilitation is already being adopted, but for the mental health, there's actually a lot of evaluation going on here. So we can actually also trying to incorporate that into the hospital record. Right now, it's not fully yet, but it's in the process of being done. So basically, if you actually look into what exactly going on a person's health, we're looking at what we call N=1, which means personalized health. And also, meanwhile, it's a population, public health, because as I mentioned, aging population is actually also a pandemic to some extent, because a lot of people living longer, develop dementia, they need a lot of assistance. That's a big resource constraint, like conditions. So that's the reason why one of the major things currently here is how to convert all the traditional hospital-centered into beyond the hospital. So basically hospital plus home-centered. And then what we call digital transformation right now, convert a lot of those into measure. One of the major issue, I'm just showing you the example here, is because to fully understand individual health, it's like a big elephant with so many things. So how do you do it together? So there's a big need for develop advanced AI, such as deep learning, based on consensus principle and the complementary principle to address this issue. But the first forefront right now, it has been going on in the US now. It's largely because the insurance start agreeing to incorporate this. That's why physicians are willing to get those into the play. So what I just shared with you is the forefront. Behind it, it's actually people are all right now understand it's important to get all this data. But however, one of the major issues is the infrastructure. How do you physically archive those, develop a personal health record for each of the patients? So for this reason, we are very fortunate to have a chance to work with Shriner Children's Hospital, their headquarters, the entire organization with 22 hospitals in the entire North America, from Mexico, US, and Canada. So it's actually no longer a talking, and talking is a chip. It's actually now we're in the implementation phase. Over the past few years, we work with them. So we actually designed this using the FHIR, Fast Health Interoperability Resource. So this actually is in action. It's already being established in the headquarters, where they actually basically build the fundamental infrastructure, incorporate the entire FHIR, and then front end, there are different, I told you 22 different hospital sites. These are the few examples that are built upon this. So all the data adapt to the FHIR, incorporated, so all the hospital sites within Shriner network, they can integrate, harmonize it to work. So one of the major infrastructure change is there used to be OMAP infrastructure. We actually help them convert that into a FHIR infrastructure. And then on the front end, on each of the hospital, they got this standard different smart on FHIR app, so they can access to the backbone infrastructure. So fundamentally, this is a summary slide talking about how the hospital is working. We actually view that we are looking at targeted population. That's why I was talking about aging or like pediatric. In fact, I wrote it here. In fact, we can also target for different rare disease population. And then largely, we focus a lot on getting the infrastructure ready so we can actually incorporate all kind of data, right? That's a major commit, like right now for all the healthcare system around North America, trying to figure out how to get a larger amount of data archived. And then on the front end, we're looking into multimodal data, how to incorporate. At some point, people even talking about social network. Right now, we haven't fully incorporated that yet. That's belong to the mental health, which happen to be the one under development. But all the other of those, combining not only the electronic record, getting the genomics in, but also personal health record at home, that's already start being implemented in the US. So overall, we are trying to build this fundamental place for handling the big data. So I want to use this as my like a final summary slides because everything we're talking about fundamentally is actually because of one reason, paradigm shift. We're really trying to move from health, sick care to healthcare. So that's why I think today's talk is only focused talking about the hospital. But what we are talking about in the future is actually should be hospital and the home integrate together for smart connected health. So the really this become the key for everything we're doing right now, what we're investing. Once we develop all the point of care devices in the hospital, right now we need to invest more into the wearable devices at home. And then with that, then when we have data, then we're in the area of the digital era. We need to invent more algorithms to handle large amount of data. So with that, I'm finishing sharing my thought. Thank you for your attention.
Thank you, Mary, for your excellent presentation and actually for bringing us some lessons that we have to learn from the other side of the Atlantic for Europe. And maybe we can implement those in Europe too. Very good ideas also. I can see all the faces of the participants looking very with a lot of interest on your slides. So thank you. Let's move now to Kostas Pattichis to see the trends in this area on AI and deep learning in the hospitals. Kostas, please share your screen.
Okay, thanks Sergio, thanks Dimitri for inviting me, and of course the talk by Anca and May I think greatly make my job easier. I mean AI is everywhere in all phases of our medical and health cycle for the early detection of disease, aid and treatment, better overall experience. It should be highlighted, though, that according to Benjamin Bell, a Scottish surgeon, AI will not replace doctors, but instead will augment them. enabling them to practice better medicine with greater accuracy and increased efficiency. And what you see here is a typical slide that AI incorporates machine learning, artificial neural networks, and deep learning. And this is a graph recently published by Fujita in Radiological Physics, simply showing the computer-aided diagnosis research progress related to AI. And of course, this graph goes with the AI trend, where we had the first generation of systems in the 60s, the second generation of CAD systems in the 80s, also aligned with the first CAD FDA approved on for digital mammography by the University of Chicago. And what we are experiencing nowadays, the third bloom in AI, deep learning. And I put this slide here on purpose. This is a paper published recently in Lancet Digital Health, where a comparison was made on deep learning performance against healthcare professionals. And as you can see here from the second graph, all the sensitivity versus 1 minus specificity, the sensitivity and specificity markings for the deep learning models are about 5% better than the healthcare professionals. And this slide shows selected FDA-approved CAD systems that demonstrate that FDA-approved systems cover a wide spectrum of medical imaging modalities in PET, MRI, CT, and X-ray. I borrowed this slide also from Fujita, showing that from the computer-aided diagnosis, using deep learning as an enabling technologies, we move to automated diagnosis. And this concept also covers CAD systems where they can be used either as a second reader or first reader, or interactive CAD, CAD for triage, and so on. However, there is a big discussion actually not only in the AI community, but also in the medical community, human in the loop. It's very important that a human is involved towards the automated diagnosis system, decision making. And here you can see on the upper right-hand side, MRI with a lesion and different deep learning technologies explanations, if you would like, in the form of heat maps. And if we see actually try to map the prediction accuracy versus explainability, we very well know that the deep learning has high accuracy but low explainability compared to other modalities. So it is clear there is a need to provide to the medical community explainable AI systems. And it's very important to note and to highlight that this explainable AI system should be trustworthy and of course cover ethical use. Anca highlighted the concept of trust. It's very important that these systems should be trustworthy, should handle the data with fairness, diversity, robustness, and also explainability. they should provide decisions or suggestions that can be understood by users. And also they should provide transparency, i.e. traceability of the system, and accountability. And some facilitating technologies that we should see in the future, I think May highlighted very clearly the importance of fire. And I think fire will play a catalytic role in the future hospital, as it will allow us to save data in shareable content format. And actually what you see here, it's a HIMSS conference, a 2019 conference, where we have the CEO of Google and IBM's CEO discussing about fire and AI. We are witnessing, of course, the COVID-19 pandemic, and this was a facilitator for the development of many technologies. I have just selected one here, that the development of a system for healthcare resource allocation on handling COVID-19 cases, that was validated on more than 100,000 cases in the state of Indiana, simply to demonstrate the potential of these technologies. Another area that is also very promising for the future, of course, is in silico modeling. You see here an example in cardiovascular disease, where anatomy, mechanics, electrophysiology, flow, and the blending of these different technologies will play a catalytic role for the handling of patient therapy. And of course, radiogenomics for precision medicine. There is a need in the clinical care that to move from the current size, where one fits all. We need to develop fair data sets, of course, data sets that should be findable, accessible, reusable, interoperable. We need automated, both automated and semi-automated and manual segmentation techniques for lesion identification, then lesion characterization, and all the imaging features combined with clinical features and omics features, of course, towards the deployment of precision medicine services, where each group of patients is handled specifically and dedicated to his care disease. And this is actually my last slide. Deep medicine model. Actually, this is based on the book by Professor Eric Tobol, on the book, his book Deep Medicine, how artificial intelligence can make healthcare human again. We need deep phenotyping. Of course, we need to collect all the omics related data, not only omics, but combined with the imaging and clinical data. We need deep learning, okay, different machine learning technologies to enable us to develop our systems to be trustworthy and explainable, but also it should be very important, deep empathy. We should never forget that the patient is at the center of our procedures and of our services. And finally, this is my last slide. And actually, May mentioned that the target is to leave the patient at home. And actually, you know, this was the case in ancient Greece, actually. Before hospitals, 500 before Christ, patients were staying at home and they were praying to Asclepios the god of medicine and healing for their health. And actually here you see in Goes the first hospital. Here I have the hospital of the future, again a slide borrowed from Google Image, and you can see all this high tech. However, we should not forget that even today, unfortunately, we don't have cure for all diseases, and it was the same in Byzantine time, and it's still the same today, that many people pray to saints Cosmas and Damianos for healing. Thanks a lot for your attention. Thank you.
Costa, thank you very much for your very focused talk on the trends and the future in our hospitals. And it seems that from all the speakers now we have a global picture of what happens with AI, and also some ideas of what it should happen in the future with AI and deep learning in the hospitals. Also, thanks to them, they addressed the issues of pandemic, and which is a use case, a special use case for ODIN. And I will start, let's say, the discussion with making the first question to May should leave in 5 minutes. Or let's say start the discussion from there and move later to the others. Okay, May, you see the hospital, and the hospital now are growing, but they have too many patients coming now, with COVID. To the proposition from Anca about federated learning, Kostas speaking a lot about, and you spoke a lot about the patients at home. How do we envisage that? I mean, patients at home and the center of the hospital, how will be the model in the future?
So that's actually, I think infrastructure is the first thing, because that's the reason why I was sharing with you this being implemented at this moment right now, because the hospital already sees a major bottleneck in terms of infrastructure. So what currently envisioning back in the infrastructure, ideally hospitals should have a private cloud, and each of the patients should have also private personal, like a cloud. Those two clouds need to have a handshake so that their home care information will be able to be easily transferred to the hospital where the clinician sits. So that's actually where I was sharing with you. That's what this hospital started implementing. But there's physically right now there's some constraint. They show me that how the patient come in, take a hard drive with them, and then they have to arrive 1 hour before the appointment time. Nurse have to be the one upload. But then the problem is to read the data, make sense out of it. That's where the AI can play a key role. So I think infrastructure is one of the, to me, is the first major barrier everyone needs to work on. And then meanwhile, a second, I think Costa mentioned about it, the future hospital care. Once we are trusting all these technology, help assisting us so we can do home and the hospital. And then the problem is physicians do not trust the AI, at least until now, the people I work with. So as a result of it, in the US, FDA officially started a group working on AI standard. The key is the reliability, reproducibility, trustworthiness of the algorithm. So the AI can be utilized, because the moment we're talking about future doing all this, then the data piled up, a physician have no time to read it. They must rely on AI. Some of the tools do it. But now, how do they trust it? I think that those to me are the two major technology like goals we can help accomplish for the future hospital, future care.
May, thank you. You can now go. Go to,
Yeah.
to this. Thank
Very
you very
nice
much.
to see you guys. Thank you very much. Okay.
Okay, thank you very much. I'm continuing this discussion.
Dimitri, may I make a comment?
Well, yeah, of course.
I think there is, to be honest, entirely different paradigm and way of handling medical care in United States and in Europe. To the best of my knowledge, in United States, at least talking to medical people, the target is not to get the patient in the hospital. It's clear. They don't want the patient to go to the hospital. Let's be honest, it's entirely different philosophy than what is handled in Europe. And I mean,
You didn't know that.
Sorry, maybe this is my understanding. Maybe I'm wrong. And you know, like the patient, like the soldiers. I'm sorry, like the soldiers that they are out, U.S. soldiers, and if you can give them something to handle everything, magic, and treat them, this is the target. At least talking to medical people in United States, this is what I am getting.
Actually, I think Kostas, you are right. You know why? Because I live in US for 30 years, but I grew up in China. So for many years, I have hard time to understand why there are no patients in the hospital, right? So that's why what you observed is correct. What the US, that's the whole reason why the US insurance right now is willing to pay for patient gathering the information at home, right? The early year, the barrier, mHealth cannot go very far is because of this. Last 5 years, especially during the pandemic, this door opened, right? So I think, personally, I do not like this initially, but now I see a value there. Basically, I think the US basic spirit is you take care of yourself. So that's why if our technology healthcare can be shifted to each individual patient, it's good for us. That's why we should do from sick care to healthcare, right? The more we do healthcare, the less we rely on the hospital. In that level, we do the monitoring, we preempt the issue. I have some good example. Today, we don't have time to talk about it. We actually have an example. We already showed that, how to preempt the patient from coming to hospital. So, but anyway, I need to run. But thank you very much for inviting me. Good to see you guys.
Bye.
Okay.
Bye.
Bye. Bye.
Thank you. And now let's move to the question to a little bit more technical items. And also, Anca, how do you envision in this, new hospital that combines home and patients in the hospital with the federated learning techniques that you mentioned, or the federated environment? How this can be applied? I mean, where are the data now? They are at the home of the patient, in the hospital. What is the future in this direction?
So I'm not, let me make it clear. I don't think that federated learning solves all our issues, but I think it is one of the technologies that can play a role in this ecosystem, and I believe it in sort of a global approach. So I do not believe that we should focus on small solutions, but really have a large ambition and scale up. And federated learning indeed can fit cross silos, so cross hospitals, in that sense, dealing with the governance issues and dealing with the custodianship issues. So hospitals are more likely to share data, but as well, you can leverage data of devices. So if patients monitor, collect data at home, you know that federated learning actually started from Google and started from devices. So in that sense, there is a continuum, and all that data can play a role here.
Okay, I understand, however, Anca, that federated learning is unavoidable when we have cohorts in different hospitals, or we have data and we like to develop, let's say, some unique workflows or unique solutions for or unified solutions for all the hospitals.
So what I believe,
Yes.
just let me say one thing. So what I believe is that we have a huge issue with access to data right now. So there is a lot of talent in the AI community to develop models, but this will not make their way into the hospital before they reach that stellar performance of 99%. And we cannot do that by developing models with the same data. You know how those challenges, they put out a data set and everybody uses the same data set. So we need to bridge this issue of hospitals having challenges and data, and the AI community having ideas but no data. So that's why we have to find a way to bring them together.
So we're coming to the question again of data sharing and data harmonization next.
Exactly.
It's also mentioned because it's very important to develop federated techniques. Costa, we have one more, time for one more question, or let's say a point of discussion. Again, you see what we discussed today. We discussed something which is very futuristic for, as you said, for Europe. So we discussed also the issue of the data, and this is the major constraint in some cases because we don't have really access to the data, or the data cannot leave the hospitals. How do you envision, the healthcare system having several hospitals that should work together? I mean, there are collaboration issues. Now in the COVID area, you see that we have to move patients from one ICU to the other. So we're coming to the question how the hospitals can collaborate and how AI can be used in that direction.
Actually, again, the situation is different in Europe, and we should keep in mind with the cross-border healthcare, as nowadays many countries actually are sharing the patient summary and the prescription and the dispensing, and the target of EU is to generate a common medical space, and the target is 2024 to share also across Europe medical images, lab results, discharge forms, and unstructured EHR data. So I think Europe is in the right direction because forcing cross-border interoperability will enforce national interoperability unavoidably. At least this is the case in Cyprus. And I have also, this is regarding medical data. Regarding the home data, no, I have been asking this question myself for 20 years now. How would it be better to handle it? And my answer is that you need two different systems. This is the medical data system, and this is the home monitoring system. And these should talk together, of course, via FHIR. FHIR is very important. It caught up in United States. It will be regulated, I think, in 2022, more regulated in United States. FHIR provides best practice. It covers also recently omics handling. So it seems to me that FHIR will play a catalytic role starting from collecting data at home to high demanding data in the hospital.
And one more question to both of you. Do you see any financial benefits, because we have not addressed any measurable financial benefits of the AI in the hospitals? I mean, are there any measures for that? This is what I mean. Anca, what do you think about that? You are coming from industry.
So I think this is the only way in which our healthcare systems will be sustainable. There is no other way. So I think there will be significant benefits in operations, so we can save a lot of money there. But I also see it's not only about cost reduction, it's also about quality improvement. So providing better care, not letting people not have access to care. I think that's also it's hard to measure an increase in quality, but we have to also look at quality, not only at costs. And I believe there are significant benefits. And I also very much believe in prevention. So can we also have patients, help patients with AI for prevention so that they don't become patients?
Yeah.
Yeah. Yeah, of course, as Anca said, prevention is the key. But let me, in the last IEEE MBS webinar, actually, the lady from GE, I cannot recall her name, she mentioned that in their portable CT system, they are doing the reconstruction based on deep learning, and it dropped their capturing time to half. This means double exams in the same timing. So this means immediate savings. So there might be indirect, many indirect benefits that to the technologies that affect, the patient handling.
Yeah, sometimes, and this is why I put this question, is that sometimes we have to think about the quality of the care, we have to think about the financial benefits, and somehow quantify them and make them measurable for the hospitals, because this is a mean for acceptance of AI and deep learning in the hospitals. So now we're reaching to the end of this webinar. I would like to thank Kostas, I would like to thank Anca, I would like to thank May. All of them are members of the IEEE team in the Journal of Biomedical Health Informatics, and they're doing great work there. Anca is doing great work with us in ODIN, and Kostas and May, we know them very well from other projects and our collaboration. Thank you very much for being with us. Thanks to our audience, and please, before closing this webinar, Sergio will make an announcement for the next one.
Thank you, Dimitrios, and thank you very much. I adhere to your appreciation to all our speakers. I enjoy a lot your presentation. I have to say that the webinar was recorded to be uploaded into the website of ODIN, so people will be able really to look again. So I think that it was very interesting presentation today that are very close related to the work in ODIN. So I have to make an announcement for the next webinar on the 24th of February. We celebrate in the fourth Thursday each month our webinar, and then just to make a reservation of the date and time. Thank you again, and then I hope that you have been a good day today, and keep safe.
Thank you.
Thanks a lot, Sergio. Thank you. Bye-bye.
Thank you. Bye-bye. Bye-bye.
Bye.
Bye, everyone. Thank you.